All right, so I'm going to get started. Sorry. So basically, I'm going to talk about some of the LVAD imaging. First, I'm going to go over a little bit about why do we need imaging in LVAD, and then what are some of the complications that we're looking for. So in patients who are on an LVAD, we're looking for LV unloading, and then assessment of regurgitation lesion, particularly aortic regurgitation and mitral regurgitation. We try to look for clots, but those are usually, if it's a pump thrombosis, we're not going to be able to find one. But what we can find is basically if root thrombosis is there, or any other obvious thrombus in the LV, but those are usually a rare find. And then we are looking for RV dysfunction and RV failure. And then the last thing is if we're trying to look for troubleshooting for alarms such as low flow and suction. So my goal is more of I'm not an imager, but my goal is to give this on from an imaging perspective. So currently we have a protocol that exists for our LVAD patients, where we have kind of described parameters for our echocardiographers and imagers as to what we're looking for and what we want to do. One of the most important protocol is for ramp, where we're trying to either see if the LVAD has optimally unloaded the patient, and other is to look for pump malfunction. This was particularly for HeartMate 2. And thirdly, we do these ramp protocols for recovery. Our goal usually is, our standard of care is that the patient should be fully therapeutic in terms of their INR. So INR goal is usually around 2 and PTT around 70. And if they're not therapeutic, we try not to do these ramp testing. And this is just a word of caution, mostly because we've had a few patients where their aortic valve was closed, and if they were not therapeutic and their aortic valve opened, if they had an underlying clot that we couldn't see very well on imaging, they ended up getting a stroke or some kind of distal embolization, or an embolus to their coronaries, which is actually resulted in some chaotic events. So we try to be directed at making sure this INR is above 2 and PTT is equal to 70. This is just a little bit about the protocol. So in terms of just looking specifically for devices, at our institution, what we do is if there's a HeartMate 2 device, usually the baseline speed is around 8,000 RPMs. The maximum you have is 11,000 RPMs, and we start by doing increments of 400. And then we look at the parameters at each of these speeds. If it's a HeartMate 3, we do 200 increments, and if it's an HVAD, we do 100 increments or 80 increments. And if the heart failure physician is available at the bedside or in the cath lab doing a concomitant right heart cath and an echo, then the increment in the speed can be at the user's discretion. So some of the times, one of the biggest challenges we have is whether we can use contrast in these patients. We've all experienced this, that LVAD imaging can be sometimes very hard, particularly because of the inflow cannula metallic artifact, and we don't see very well on imaging. And so this was from JACC Imaging, where they did say that you can use echo contrast and it is safe and feasible to use it, particularly if the question is around understanding whether they've had recovery or if you're looking at RV function. Then the other thing that we kind of standardize at our center is that whenever we do any kind of study on these patients, we do use echo contrast to also look at the root, because the root thrombus is better seen on CT scan with contrast. But if you use echo contrast and you see kind of a defect at the level of the aortic root, usually in a peristernal long image, it can be better seen with contrast. So before doing any kind of ramp studies, we do this. So just as a reminder to everybody about the devices that we're using currently, we have the HeartMate 2, the HVAD, and the HeartMate 3. HeartMate 2 and HVAD are no longer used, and currently the only device that we're using is HeartMate 3. But because some patients are still being supported with HeartMate 2 and HVAD, I'm going to still mention it in my presentation today, but maybe in a couple of years, this would be limited to either HeartMate 3 or the newer devices that come through. So the difference between these three devices is basically that HeartMate 2 is an axial flow pump. where blood basically flows in parallel to the pump. And HeartMate 3 and HVAD are basically centrifugal flow pumps, and blood flows in perpendicular to the pump. And these are pericardial pumps, which means that they inflow canalize at the LV. And in all three devices, the outflow canalize in the aorta. This is just a table that helps us understand the differences between these devices. As I mentioned, HeartMate 2 is an axial flow pump, and the pump sits outside the inflow canalize in the LV cavity, and the pump speed ranges that I mentioned earlier. HVAD and HeartMate 3 are centrifugal flow pumps, and the pump speed parameters as I listed here. The goal anticoagulation is generally the same, INR 2 to 3 for all three devices with aspirin. These are just a console, the differences in them. So if you look at the first image, that it shows a speed of 9600. This is HeartMate 2. Other parameters that you can look at on the device are pump flow, the pulsatility index, and pump power. The HeartMate 3, which is on the far right, looks a lot like the HeartMate 2, whereas the HVAD has a little bit of a different console. It is an iPad that shows us basically not only the pump parameters, which are the flow, the watts, and the RPMs, but also it shows us a graphic representation of the peaks and troughs of different parameters. And we can go as back as 60 days to look at what kind of alarms have happened. So what do we as heart failure clinicians worry about or care about when somebody's interpreting the echo imaging for patients who are on LVAD support? So what we are really interested in is just looking at this image, we can see that in a peristernal long view, the aortic valve is closed, so that's important and worth mentioning. And if we on color see aortic regurgitation, that's important and worth mentioning. We are interested in mitral valve, whether there's regurgitation or not. We want to understand what is the LV end-diastolic dimension. Sometimes it's very hard to image the inflow cannula, but you can see there's a shadow coming in closer to where you see the 10 mark. And it is hard to do the Dopplers as well because we don't get good alignment, but that's also something we're interested in if it can be imaged appropriately. The other important issue is about the right ventricle. So an assessment of the right ventricular function is key and important, and assessment of LV function for that matter is also important, particularly in cases where we are looking for LV recovery. This is an M-mode across the aortic valve. Now this image that I showed you in the last picture, the aortic valve was very well visualized, but there are definitely cases where we don't see the aortic valve very nicely. And so in that situation, M-mode is our friend. Then it can tell us whether there's aortic valve opening or not. It can also tell us the duration of the time that the aortic valve is open. And if you put in cup color along with the Doppler, you can also see if there's any regurgitation there as well or not. Now, the other important view, of course, is the four-chamber view. Here, what we're looking for is basically what I call the LV-RV interdependence. So the physiology changes a lot once you are on LVAD support. And the inflow cannula interaction with one, the septum, and two, the interseptum, the septum interaction between the LV and RV, whether it's deviated towards the left or it's deviated towards the right or it's midline. Preferably, we want to have it in the midline to prevent one, suction, and two, if there is a lot of RV dysfunction and the RV essentially it gets really enlarged, the septum can be completely deviated towards the left, which is also an important finding to look at. Similarly, the interatrial septum, the relationship between the two atria to see if it's deviated towards one side or the other to kind of give you an assessment of the relative differences between the RA pressure and the LA pressure is what we're interested in. Again, hard to see in this image, but inflow cannula is something we want to visualize. And again, if we can get a good alignment in terms of Doppler, then it's beneficial and can help us in some ways. But there are no studies where there's been well alignment, and usually we don't use it clinically. It becomes irrelevant if the alignment is not proper. So I also caution people to not over-interpret what we see on imaging by echocardiogram, particularly when we talk about Dopplers. Now, this is inflow cannula position is another important focus. Here you can see that the inflow cannula is really abutting the septum. This is somebody who had been having a lot of arrhythmias, what their presentation was, that they were having a syncopal episode anytime they bear down. So this is where it is important to understand the position of the inflow cannula relative to the septum. And I'll talk about this in my talk a few slides later. It's also important to sometimes exhibit or demonstrate what happens to these patients when they change their position. So if you don't know exactly what happens, you can try to make them do some certain maneuvers to see if you can replicate a suction event. Sometimes it's very hard to capture. CT imaging is great also to look at it, but at the same time, proper suction, sometimes it needs the patient to demonstrate those same maneuvers, or going from a sitting to a standing position, to kind of see if this inflow really gets suctioned and does cause complete occlusion of the inflow cannula, resulting in syncopal episodes in VT. So this is also important, and this patient had that when we changed his position. This is a Doppler. Again, as you can see, the alignment is not proper, and it is extremely hard. And in these situations, again, caution is to not overinterpret, but to get a reliable signal wherever we can get it. More important is outflow cannula. If we can get that signal, but again, it's very hard to visualize. We do tell people to try to get the right upper sternal border and try to do their best to see where we can see the outflow cannula, and we can then do Dopplers across the outflow cannula as well, and see if we can do what we now call the S to D ratio to demonstrate if there's demonstrate the severity of aortic regurgitation. I'm going to talk about that in a little bit later. But if, again, same issue, if the alignment is not proper and you cannot properly see the outflow cannula, then this information can be useless. This is a very nice outflow Doppler, as you can see here. This is from a patient who's on HeartMate 3, and we can see that there is a nice waveform systole, diastole. The blood flow completely drops to zero during diastole, and there is basically some degree of pulsatility from the patient. As you can see, the differences between the systolic and the diastolic. The other important thing to consider is IVC assessment in these patients, because what we're trying to assess is whether, or get an estimate of, is their RA pressure. Sometimes clinically, it's very hard to understand what their filling pressures are like, particularly from a right atrial pressure perspective. And so it is important to see the IVC if it is very dilated. JVP may not always be reliable in these patients. So at least in clinical practice and in patients, we try to assess the IVC to understand whether we want to diurese them further and whether they need proper hemodynamic cath to understand if they're having RV failure. Other important things to consider is recovery. So we definitely, if not every patient who is on LVAD support has an LVEF of less than 20%, there's definitely patients who do recover, even though, I mean, the proportion of patients who do recover is far less, but we do definitely use echo to understand whether the LVEF is improved, to see if we can, we've had a few patients where we've decannulated them and they've recovered their LV function. So it's important to also talk about LVEF in a more granular way. Now, the issue again is with imaging planes, and there have been some studies. This is a study from Europe where they've looked at how to get better imaging planes for patients on LVAD support. Again, because of the issues with not being able to see imaging very well in these patients. So there's some newer views that may come into play in a couple of years. This slide is from a couple of years ago, but definitely we can use CT to understand which are better views. This is kind of a subcostal type of a view, and you can see such much better images in this, and including imaging of the outflow cannula. So definitely, I mean, there is room for more research and understanding other ways to image these patients where it's hard to image by regular views. Particularly some of the other specific imaging specific nuances for LVAD patients are that they do have these artifacts, particularly from the metallic device. It's I call it the waterfall artifact, and it's usually we see that more in HVAD, and it looks almost like a either it's snowing on the Doppler or there's a waterfall on the imaging. Color imaging. So this is one thing to consider. The other thing is sometimes I get a call from the echo lab that, oh, we see this retrograde flow on patients who are particularly on support with HeartMate 3. and whether that's abnormal. And, we have to tell them that this could be the Lavare cycle. If it's activated, that, there's a retrograde jet that it does a washout every few seconds. So that's not something that we need to worry about per se. It is something that it has to do with the design and how the Lavare function of the LVAD. So why do we need imaging in these patients? A lot of times when we do consider imaging, we're asked why we want an echo, a follow-up echo on LVAD. It is important to understand that if you're not hemodynamically well supported by the LVAD, there is a higher likelihood of having bad outcomes. And these outcomes are the hemocompatibility related adverse events. So if you're decompensated and you're not appropriately unloaded from the LVAD, it was clearly seen that those patients actually did worse and they had higher risks of having one, of course, heart failure hospitalizations, but they also had higher risk of having stroke, VT, GI bleeds, and pump thrombosis because of ineffective unloading. Similarly, definitely, echo is one parameter, but hemodynamic assessment is better. And this study that was called the RUMP-IT-UP study, they looked at 22 patients with a hemodynamic group and a control of 19 patients. So patients who had hemodynamic assessment and were appropriately unloaded based on their hemodynamic studies did better than those who were not frequently followed by hemodynamic assessment. So what does unloading mean, or what is an unloaded heart by LVAD? So basically, if it is optimal when you don't have aortic valve opening, or the aortic valve opening is intermittent because there's enough pull from the LVAD that it causes appropriate unloading, and hence the aortic valve doesn't open anymore. However, aortic valve opening is not the only thing that you need to make an assessment whether there's appropriate unloading or not. Some people just look at the aortic valve and they think that the aortic valve is closed, so then they're appropriately unloaded, but that's actually not true. The other important things that we have to look at is, again, the interventricular septum, whether it's midline or not. The presence of mitral and aortic regurgitation is minimized. And by, of course, hemodynamic assessment, whether their filling pressures by echo or by a right heart cath are normalized, meaning that the wedge pressure is below 18 and the central venous pressure is below 12. And by echo, that means that, your mitral valve E to A peak Doppler velocity is less than 2, and your PA systolic pressure is less than 40. Again, mitral regurgitation minimized as much as possible. And then the LV and diastolic dimension, whether it has reduced appropriately by increasing the LVAD speed, without causing a significant shift in the interventricular septum and causing suction events. So we actually, at Houston Methodist, Dr. Nagueh did a study along with Dr. Estep looking at the hemodynamic assessment of patients who are on LVAD support. And this was a study done, a concomitant echo and right heart cath, which demonstrated patients who have an RA pressure of less than 10, diastolic pressure less than 40, and a volume index of less than 33, and E to E prime less than 14 had been appropriately unloaded and had a wedge pressure of less than 15. And so those are patients that you won't do any changes to, but if they have elevated filling pressure where you see the E to A ratio is greater than 2, and they have, for instance, a systolic PA pressure of greater than 40 and RA pressure of greater than 10, then you would think that these are patients who have an elevated wedge pressure and they may need augmentation of diuretics or medical therapy for that matter. And so this is an example of how an unloaded and not so unloaded LVAD patient would look like. So if you look at figure 1, this is from somebody who has normal filling pressure. So you can see a nice E to A ratio. E prime, of course, is reduced, somebody who has had cardiomyopathy, and then the PA systolic pressure is normal. And similarly, in figure 2, you see that elevated filling pressures with the E to A ratio that looks like it's greater than 2. Again, the E prime is reduced because of the cardiomyopathy, but the E to E prime ratio is 15. And as you can see, the PA systolic pressure is estimated to be 48. So this is somebody who's relatively not so very unloaded. So a lot of this information we can gather from echo alone. And my first step, at least in clinical management of these patients, is to do an echo first. And if I cannot get my answer appropriately, by echo, then next step is to do a right heart cath and consider doing a ramp with concomitant echo to see how we can benefit these patients. There's definitely a role for three-dimensional echocardiography. This is a study done by Dr. Reel and his group, where they looked at a marker called sphericity index and looking at if the changes in LV and RV morphology with the higher LVAD speeds, and whether it's becoming more convex for the RV or there is increased concavity. And some of these parameters, although they've not made it to clinical practice, but this change in the RV morphology and the LV morphology can give us clues to whether this is, one, an appropriately unloaded heart, and two, are we making the RV function worse by changing the shape drastically. I'm not going to go into all the details of the sphericity index and the convexity and concavity, but this could be something that could be worth of clinical importance in the future. When we do see somebody who has a partially unloaded LV, then we have to go through the differentials as to why do they have partial unloading. So the first obvious question is whether they have low pump speed. So definitely in that situation, you would want to increase the pump speed, and that would be your obvious answer. The other thing that is important from an LVAD physiology perspective is that hypertension or any type of excessive afterload, whether it's in the form of high blood pressure or it is in the form of outflow kinking, will increase the afterload on the LVAD, and that would make the LVAD's ability to unload would hamper the ability to unload, basically. So basically, you have to look at what the blood pressure is at the time of doing the echocardiogram. The other important differential is inflow cannula malposition. Now, in some patients, the inflow cannula is completely malpositioned and is deviated towards the septum. And so increasing the pump speed causes more suction and septal deviation. And as a result of that, we're not able to unload these patients appropriately. Other important differentials are, of course, pump malfunction if they have rotor thrombus. And just a note on this that, we used to see, of course, pump thrombosis is common was very common with HeartMate 2, and with HVADs, it still occurs, but it is far less with HeartMate 3. We don't see that very often. And since we've transitioned from completely doing HVADs and HeartMate 2s to HeartMate 3, this might be lesser of a problem in the future. And the other important differential is acquired continuous aortic regurgitation in these patients. And that the reason for that is that there is commissural fusion, and over time they develop aortic regurgitation. Some patients may even have pre-existing aortic regurgitation that can get worse afterwards, but this is a phenomenon that happens because of what we think is valve leaflet atrophy. What this does is it creates kind of like a closed loop. So whatever blood should be flowing forward from the outflow into the ascending, into the arch and then descending aorta, it gets some of that leaks back into the LV, and as a result of that, you don't have effective unloading. It is considered a common problem. Up to 49% of the patients, by one estimate, had moderate to severe AI in some studies, but in some other, it's very institutional. Some centers think it's not very common, but there are definitely things that we can do once we do establish that there is significant aortic regurgitation. It is bad because it has been correlated with adverse events, particularly, again, the compatibility-related adverse events are higher in patients who have had aortic regurgitation. And this was demonstrated in a study done by Reel and his group. So as you can see here, we are not very good about assessing aortic regurgitation in these patients, again, because as you can imagine, the usual traditional echo parameters that we use, such as vena contractor or PISA or something, that it is harder to think that this would be applicable to somebody who has an LVAD and there is a constant suction from the inflow cannula. Nonetheless, currently guidelines still recommend that the vena contracta greater than 3 and jet width to LVOT width greater than 46% is considered severe. Of course, in some patients where there is severe regurgitation and they have clinical heart failure, it's easy to make that determination. But for patients with moderate lesions or mild lesions, it's harder to demonstrate really what their severity is. This is somebody who has, again, severe aortic regurgitation, came in with NHI class 4. As you can see here, there's a lot of color flow. And this patient clearly had somebody who had severe aortic regurgitation. Again, determination of mild and moderate is harder, but severe maybe with clinical context could be something that could be considered worth fixing. Now, coming to a newer method to measure aortic insufficiency is by this diastolic flow acceleration and systolic to diastolic peak velocity ratio at the outflow cannula. That was done again by Dr. Reel and his group. So what they did was they calculated the aortic regurgitation flow by using both right heart cath and echo parameters. And they looked at the total systemic flow using cardiac output across the LVAD outlet and the cardiac output across the aortic valve, and then looked at the flow on the right side of the heart. And by looking at the total systemic flow minus the cardiac output that the right heart sees, you can basically get an estimate, or I call it a guesstimate, of what the aortic regurgitant volume is. Of course, this paper can be, it is the best we have, but there are certain definitely estimations or conclusions that we're drawing. Maybe they can be grossly overestimated. But currently, this is something that has helped us understand maybe aortic regurgitation severity a little bit better. So what they did was they looked at in a well-aligned outflow cannula, looked at the diastolic acceleration and then the systolic to diastolic ratio. And this was then correlated with the regurgitant fraction. So if you look at this table, and this is from the same paper, that in patients who have a trace or mild AI, the systolic to diastolic ratio was elevated 6. And the diastolic acceleration was around 35.7 as compared to when people had severe AI, the diastolic acceleration was 68.7. The systolic diastolic ratio is around 2.6, and that correlated with regurgitant volume greater than 40. So this is one way to classify again, but this in clinical practice is hard to use because we sometimes are not able to align the outflow cannula very appropriately. And just in our clinical practice, what we've noticed is that, you can probably get better alignment with using ICE in certain cases that we've used, where you can see the outflow cannula much, much better and can align the doctors much better with the ICE catheter in the cath lab. In our just effort to understand aortic regurgitation better by using, we did a mock circulatory flow loop, and which was echo compatible, and using a patient who had a HeartMate 2, and this with a 3D patient specific anatomy. And in this mock model, at least, what we were able to replicate some of the aortic regurgitation that the patient had. And what we basically saw was that this echo parameters are usually overestimated, which is actually not surprising. And maybe there was a signal that there is some truth to the systolic to diastolic ratio and the diastolic acceleration time. So that's something that could be considered, can be used in clinical practice, provided that there is appropriate alignment with the outflow cannula. Again, just a little bit about the pump thrombosis aspect, even though, like I mentioned, that HeartMate 2 and HVADs are no longer being clinically used, but definitely we have a lot of patients still on support. So the best way to assess for pump thrombosis is, of course, by looking at the LVAD console and looking at the hemolysis panel. Echocardiography is helpful, but is not useful in certain situations where there is hemolysis going on, but there's no complete obstruction. So as you can see in this diagram, so first hemolysis starts, you start having fibrin deposition, and then after that, the thrombus starts propagating, and subsequently, what ends up happening is when there's complete occlusion, then it is a major emergency, and then there's pump stoppage, and this is a significant problem. However, echo, if there's still blood flowing, the LVAD can still unload the ventricle. Therefore, you may not be able to detect it by echocardiography. So again, it's just is a diagnosis that you make all of this in conjunction. But having said that, in some cases, of course, we had this study. One study done here at Methodist by Dr. Yusuf, another one by Dr. Rio, where they looked at the RAM study, particularly for the axial flow device again, and looking at LVN diastolic dimension, LVN systolic dimension, AV opening, unloading in the form of reduction in AI and MR, and then the RV systolic pressure could be helpful in understanding if the patient has a partial thrombus. And there's multiple parameters that we have to look at. I'm not going to go into details of this, but if there is an obvious malfunction, you can see that the LV and diastolic dimension doesn't reduce, the aortic valve stays open, the output doesn't increase appropriately, and the mitral inflow doesn't suggest appropriate unloading. However, there can be issues with this test because there can be false positives if you have a significant aortic regurgitation or excessive blood pressure. So I think these are things that we look at. This as just an echo image showing reduction in LV size in somebody who has normal pump function. And this is somebody who does not have an appropriate pump function, and therefore you see that the LV doesn't unload appropriately. Finally, just a few words on RV failure. This you can see a humongous right ventricle, and then it has the septum's completely shifted towards the left, and the LV is super tiny. This is in an acute setting where we had somebody who had RV failure post-operative and very drastic appearance where their index had completely dropped and RA pressure was in 20s. And in this situation, what we simply did was reduce the pump speed, and the septum actually came back to midline. These are some of the maneuvers that we can use. Again, this highlights the LV-RV interdependence, and as you can see that if the RV is enlarged, it can push against the interventricular septum, cause suction. Similarly, if the cannula position is very off axis, it can cause suction regardless of the septal position. And this is why it can be helpful in understanding some of the alarms. Now, one of the alarms that we see is low flow alarms. Usually that can be in the setting of RV failure, or it can be in the setting of hypertension. There can be, in some situations, pericardial effusion that actually can cause low flow alarms as well. And this patients with LVAD are very sensitive to pericardial effusion, even if it's a small one. So it's important when we're doing an echo to see what if they and mention any kind of effusion that they have, because even a small effusion can cause a significant problem. Again, this is somebody who had elevated CVP, low index, low flow alarms, hypotension. So important to differentiate pericardial effusion versus RV failure. And this patient went for a pericardiocentesis, and then there was complete resolution of the low flows and everything normalized. So it was not really RV failure, but here's where echo was very helpful. So I think this is my final slide, but what we need to pay attention to when we're doing imaging on these patients, again, my talk is completely from a clinical perspective, but it is important to look at the device type and their blood pressure at the time of doing the echo, look at the LV size, particularly changes with the pump speed, RV size and function, the IVC, aortic valve opening. I do care about the LVOT TBI if there is aortic valve opening. Then if looking at the pulmonic valve and RVOT TBI, if it is feasible. Severity of aortic regurgitation, I think it's safer to say that we cannot quantify exactly if it's mild, moderate, or severe, but we can just say that there is significant aortic regurgitation. And then presence of mitral regurgitation and tricuspid regurgitation is important. And then looking or paying close attention to the root. If there is a suspicion of like a root thrombus, maybe contrast imaging can be helpful, and it is safe to do. And inflow and outflow cannula position, if there is appropriate Doppler across it, it's helpful. But to be honest, inflow, I've not seen well-aligned inflow cannulas. They're maybe 25% of the time. Outflow cannula, we should try to make an effort to do a right upper sternal border, because that information can be useful, particularly in patients where we are. And then it's important to mention the pump speed at either the start of the echo or on the images, so that we know which pump speed this image was taken at. That's the end of my presentation. I'll hand it over to Dr. Chang. Thank you very much.
So the indication for CT, in summary, is when you have a thromboembolic event in patient with LVAD, you want to look at for source emboli from the heart, aortic root, inflow cannula, or outflow graft. Or you want to troubleshoot, as Dr. Kassi mentioned, in low flow alarms, looking for any suction event, kinking, twisting, or any extracardiac finding, such as in cases of persistent heart failure, look for RV failure, tamponade, and aortic regurgitation, and the position-related ventricular tachycardia, usually related to inflow cannula malposition. And the PET CT, I'm going to mention briefly. The obvious indication is to assess the source of infection. Okay, this is just an example of sometime if you want to see a cannula position, a gated non-contrast CT could be useful. For instance, in this case, patient has in a non-contrast CT, there's some suspicion possible malposition. This is a corresponding CT with contrast, okay? Or this case with the outflow cannula kinking, non-contrast images, and confirmed by contrast images. So just want to let you guys remember that if you have a patient, you don't want to give contrast and you want to see gross anatomical structure in the position, non-contrast CT sometimes provides the answer. This is just some example of the cannula position. This is very well placed. You can see pointed toward mitral inflow. This is case of inflow cannula with malposition with suction with Harmony 2 with corresponding very high Doppler velocity and turbulent flow. And you can see the tip of the inflow cannula is shadowed with by the LV wall. And this is an interesting case. I think patient maybe is over unloaded, I guess. LV is very small. Although the position of the cannula probably originally wasn't bad, but because the cavity becomes so small, they could have some suction of the pub muscle into the cannula. And this is just a case of patient with inflow cannula thrombosis in Harmony 2, which fortunately we don't see that often with Harmony 3 at all. So this is a normal anastomosis with the Harmony 3, perfectly nice and white. It's interesting, the hardware, usually the anastomosis site is narrower. This is just some interesting case on usual course creativity of the surgeon and putting the LVAD and then how to connect the outflow cannula to ascending aorta. And this one had connection to the descending aorta. Right with left, right, and right to left here. And this is a case of kinking. I showed you earlier, the 3D rendering. And this is what we call pseudo-aneurysm of the anastomosis site of the outflow cannula with the ascending aorta, most likely due to infection. Other thing that we can see in the outflow graft is due to twisting of the twisting of the cannula, which made a Teflon material, and with time, you can produce a similar to the tamponade physiology. Or this dramatic cases outflow cannula thrombosis. Or this cases still we don't know what it means. Or this strain that we see inside the outflow graft. We don't know quite that, again, what that means. It is just fibrous material of mitral thrombus. And this is before the recall. There was some mid-relief disconnect with Harmony 3. This has been fixed. You can see this is disconnected. So with the new Harmony 2, I think Harmony 3 was seeing less problem with the inflow cannula, but the outflow cannula still present a challenge. And the other major structure that we like to analyze is aortic root. Thrombosis happens, especially could be related to the aortic valve closure. So you can see this thrombosis in all three coronary sinus. the traditional teaching is that non-coronary sinus is more likely to have thrombus because there's no coronary flow. But our experience has been it could happen anywhere. As you can see right here, this is the case of patient I'm going to show you later with thrombosis of the RCA secondary to the clot formed in the right coronary sinus. And the other thing that we're seeing sometimes is what we call stasis. I'm sorry, look it back. Stasis that you see in the sinus, which is unknown clinical significance. And this is a case courtesy of Dr. Caravante from Minneapolis Heart, is a patient with prosthetic valve, HOT, and patient has also a LVAD. And in case, some cases, the echo has demonstrated continuous AI. Sometimes you can do a TE to look at the aortic valve structure, but with CTE, you can see the aortic valve quite well to assess sometimes the mechanism of the aortic regurgitation. And the causes for heart failures, we have a couple of collection of cases, a patient with bilateral PE, otherwise no other problem, the patient with severe RV dysfunction, in this case of possible effusive constrictive, as you can see, right, it's a little bit of fusion, and RV appears to be all here to the chest wall, and the frank tamponade, the patient with BiVAD. So just a couple of interesting case. 65 years old, LVAD, GI bleed, and possible echo. Possible clot in the echo, as you can see, very turbulent flow. And patient also had a TE showing suspicious infocanalative obstruction with high velocity. So question is, what caused the obstruction? So you can see right here, there's no clot. And essentially, this is probably the suction of the, this is probably a triangulation into the infocannular tips, as you can see right here, causing the turbulent flow that we saw in echo. Another example. This is a case of patient with ischemic cardiomyopathy with a HARMA 3 and is in anticoagulations. So you can see all this strand here. I think I showed you guys earlier, which we don't know really what it means. But this patient does have ischemic stroke. And this is something that's been described, as I mentioned earlier, the twisting of the alpha graft, and was treated with a stent, as you can see right here, with the improvement of the flow. And this is a case of the patient with thrombosis of right coronary sinus, resulting in inferior wall myocardial infarction. It's a patient with non-ischemic cardiomyopathy. You can see the echo global, but inferior wall looks akinetic. You can see right here, the thrombus extended into the proximal RCA. And patient received thrombolytics with some improvement of the clot burden. And this is a case of a patient with HARMA 3 as destination therapy, recurrent bacteremia. As you can see, this is a non-contrast CT. As I mentioned earlier, just give you some indication that something was wrong. This is alpha graft, this is the acineura, so all this structure is abnormal. This is prompt contrast CT. So this definitely looks like a pseudoaneurysm, an anastomosis site. And the diagnosis was made with gated CT. You can see the contrast spilling from the anastomosis site into this cavity. Okay. And this is, as I mentioned earlier, this is highly suspicious of some chronic infection process. This image courtesy of Dr. Amala. You can see the diffuse FDG uptake across the LVOD, but particularly in alpha graft and the wall of the collection, the pseudoaneurysm. So this is indication, clear indication this is infectious process. Okay, that's all I have. I think we're open for question. So Dr. Kassi, what situation do you order most time a CT after echo? What?
So I think what's worth mentioning here, since that we find CT very useful in our clinical practice, and what we've started doing is we do a CT at baseline, and after every patient who has had a normal kidney function, we kind of assess what their LV, RV dynamics look like, what does the outflow cannula look like, how well placed is the inflow cannula, and then if they ever have any complications or they're having alarms, we have something to go off of as a baseline. This is particularly important if somebody has an outflow kink that develops in the future, or if they have a new thrombus that develops somewhere. So we definitely do it as a surveillance in patients who have a normal kidney function, and then we do another CT scan whenever it's clinically indicated, meaning if they've had an event, then we'll do a CT scan at that point in time.
Is there a limit for renal function? You will not do a contrast study?
So we typically make sure, try to make sure that their GFR is above at least 40. And then, we have of course, a very good understanding with the CT department here. Dr. Chang has really led that effort and try to limit the contrast use and see if we can get images with lower contrast. But generally, what in clinical practice, what I've seen at least is, and we did like a small study on this, is that it's well tolerated. They don't develop any contrast-induced nephropathy, and if we can limit or change the protocol of how the CT is done, which you can maybe mention more details about, Dr. Chang, they don't have advanced kidney dysfunction.
Yeah, I mean, it's been really productive, and we enjoy seeing this type of patient that taught a lot. And the key thing is, CT for now is still anatomical test. We can look at gross ejection fractions, but for hemodynamic changes, it's always important to correlate with the echo finding.
Yeah. And I think we just have a lot of fascinating examples. I mean, Dr. Chang went over CT scan, but in some ways, I mean, definitely echo is good for hemodynamic parameters for surveillance of LV unloading and understanding regurgitant lesions. But I find CT super helpful in these patients. And then definitely, I think if they have an infection, it's important to understand how the degree of infection, for that we do the PET scan. So that's our next go-to important test. In our institution, at least, we do consider doing full exchanges in these patients if they have a very infected LVAD that includes the outflow, inflow. Then we plan the surgical operation accordingly. They needed a full exchange. So for us, it's all these other imaging. I think echo alone would be incomplete. I think the CT and PET add a lot to our clinical practice for sure.
Yeah, last question I have for you, Dr. Kassi, is I kind of mentioned that maybe I'm overstating. Do you think with the HARMATE 3 and HARMATE 2, the inflow cannula complication has been less prevalent?
So with the HARMATE 3, yes, we have definitely less pump thrombosis. We still have patients who have strokes. We still have patients who have the other complications, but definitely these hemocompatibility related adverse event, particularly pump thrombosis, is significantly reduced. Other complications are lower, but not eliminated. But imaging still, particularly with CT scan is helpful. So that change has occurred, but as I mentioned that, HVAD and HeartMate too, we still have a lot of patients that are still on support. So I think that it still is important to, do the RAM studies to look for clots, address pump thrombosis where it needs to be addressed. But as you know, that the pump it never shows the clot. We just have to do a clinical diagnosis based on what we see.
Yeah. Quick question about the aortic root thrombosis. Do you guys usually try to adjust the speed, allowing the aortic valve to open, or you don't think that's
so we did
that's true risk factor for thrombosis?
So since we of course did our looked at all the scans for a few years, and we saw that there was that there is root thrombosis, and whenever it happens, it can cause devastating complications. What we've done in terms of being extra cautious with our patients to make sure that when we're doing any kind of speed changes that they don't have aortic root thrombus is that we have this surveillance CT scan that we do. We try to time their CT scan ahead of the actual RAM study. And then if in those patients who have abnormal kidney function, we cannot do the CT scan. We do an echo with contrast to make sure that they don't have a root thrombus. So that's in our protocol. We follow that very religiously because we've had a few patients where once the aortic valve opened from a closed situation, it caused a devastating complication. So that's certainly something that we do as protocol now here. I'm not saying that this is something that's applicable to every center, but this is our way of making sure that they don't get a stroke or an embolic event. The rate of that happen is maybe not super significant. It also depends on how the outflow canal is attached to the ascending aorta, but it is definitely, when it happens, it has serious consequences. So that's at least how we ensure that the root thrombus doesn't cause problems for us. But
that makes sense because that's that part of the cause of stroke is not fixed with a new device, right? Because it doesn't matter what device it is, that's always going to be an issue, right?
Correct. And then we don't necessarily change the pumps or lower the pump speed to cause more aortic valve opening to prevent thrombosis, because we don't know if that is going to, in the long term, an unloaded heart has complications. So.
Yes.
I think that's it, right, Dr. Chang? So
Okay.
Thank you so much, everyone, for listening to us. And if there are any questions, we're definitely available by other means also. Thank you.